whether it is the gestational diabetes or whether it is type 2, type 1, which gets carried over in diabetes. So we cannot have any better speaker on the subject. And I hope that all of you will be benefited from the talk which Madam is going to do. Madam is Dr. Shalini Jaggi, and she is from Delhi. And she has recently been sworn in as the president of the Dipsy Society. And she has been running a diabetes clinic since long in Delhi and been working in this field. So I will request Madam to please carry on with the class. And if there are any queries and questions or comments, I think you all can put that on the chat box and we can discuss later on. So Madam, please carry on.
Sure. So thank you so much, Dr. Puneet, for that warm introduction. And I'm so happy to be here today. Diabetes in pregnancy is a topic which is very, very close to my heart. So I think today, when we are talking about the increasing burden of diabetes, and as UGs and PGs and doctors, we all come across a lot of patients who have diabetes. It is very important that we understand what exactly is diabetes, especially in the context of pregnancy. What are the things that you need to keep in mind so that you can optimally manage, and why it is important to manage diabetes in pregnancy? What are the problems that can happen if the glucose levels are not controlled? So I'll try, it is a very comprehensive topic, but in the next 45 minutes, I'll try to give you a bird's eye view of all the different types of classifications that we use. What are the terminologies that are currently used globally? How do you screen for gestational diabetes? What is the difference between gestational and pre-gestational? And how does the management differ for each of them? So earlier we used to talk about gestational diabetes as a separate entity, pre-gestational diabetes. We used to talk about, type 1 in pregnancy, type 2 in pregnancy. Now, WHO and FIGO have coined a term called hyperglycemia in pregnancy, or HIP, which is the umbrella term. And all the different types of diabetes or dysglycemia in pregnancy fall under this term. So hyperglycemia in pregnancy includes pre-gestational diabetes, which means a woman who already has diabetes, type 1 or type 2 or any of the other forms of diabetes, before she gets pregnant. So she already knows she has diabetes and then she is planning a pregnancy or is conceiving. So that kind of diabetes, what we call is pre-gestational diabetes. That means she had it before the pregnancy. Now, DIP, or diabetes in pregnancy, is a new term. This includes all the women who are diagnosed with diabetes for the first time in pregnancy, especially in the first trimester. But how it differs from GDM is, in DIP, if you look at the glucose levels of the lady, her fasting and postprandials fall in the WHO criteria of diabetes in the non-pregnant state. That means fasting more than 126 or a random or 2-hour post meal more than 200. So this means that maybe this lady already had diabetes before she got pregnant, but she was never diagnosed or screened. Now, when she's pregnant and she has undergone the screening, you have picked up diabetes. So this is called DIP, or diabetes in pregnancy. And the management for DIP is same as the management for pre-GDM. Now, gestational diabetes is essentially diabetes which we say is happening because of the increasing insulin resistance, the placental hormones that cause a diabetogenic stress leading to insulin resistance and dysglycemia. Earlier, we used to think that this occurs only in 24 to 28 weeks of pregnancy or in the later half of pregnancy. But now, with the increasing burden of diabetes and pre-diabetes, we are seeing a lot of GDM happening much earlier, being diagnosed as early as 12 weeks. And there's a new entity called eGDM, which we have started talking about, wherein you are picking up diabetes at less than 10 weeks. But again, these are the ladies where the HbA1c is still not in the diabetic range. That means, DIP, the HbA1c is 6.5 or more. Fasting is 126 or more, PP is 200 or more. But in true GDM, the fasting and the PP are not in the frank overt diabetes range, but there is some degree of dysglycemia that you are picking up. So this is GDM, and usually GDM, most of the women after delivery, if it is true gestational diabetes because of the placental hormones, it reverts back to normal. There is a remission, but these women are at an increased risk of developing diabetes later on. So I hope the terms are clear. Pre-GDM means already she has diabetes and then she is getting pregnant. DIP, probably she had diabetes which was undiagnosed, but is diagnosed in early pregnancy at the ANC visit, and she meets the WHO criteria for type 2 diabetes diagnosis. GDM is actually which is occurring in the antenatal period and is not expected to persist postpartum. Now, whenever we say burden of diabetes is increasing, this is the latest IDF atlas, the 11th atlas, which shows that the global prevalence of hyperglycemia in pregnancy is almost 20%. So, in the last 25 years, we started by saying the global prevalence is 11.5, then it went up to about 13 or 14. Every time that a new atlas comes in, the numbers keep going up and up. So as of today, it is about 20%. Then out of this, 80% is, like I said, gestational diabetes. About 11% is pre-gestational diabetes. That means women where diabetes was detected prior to pregnancy. And about 10% is cases where diabetes is first detected in pregnancy. This is the DIP. Now, if you look at the region-wise distribution, clearly Southeast Asia has the highest prevalence of hyperglycemia in pregnancy. So you can see, I told you the global prevalence is 19.7, about 20%. But in Southeast Asia, you can clearly see 28%. And in India, the prevalence is much higher. So 1 in 4 live births in the IDF Southeast Asia region are affected by hyperglycemia in pregnancy. This could be pre-GDM, this could be DIP, or this could be GDM. Now, before we understand what needs to be done, we need to understand what happens in pregnancy. Why does gestational diabetes happen? What goes wrong? So, before we talk of pathology, let's talk of normal physiology. Now, why does the maternal metabolism change in pregnancy? Well, the answer is simple, because it has to accommodate a rapidly growing tissue transplant or the conceptus or the fetus. So this conceptus or this fetus brings about alterations in the maternal fuel metabolism and hormones so that the maternal nutrition, the maternal nutrients can be diverted towards the fetus for its growth and development. Which organ does that? Placenta. So placenta facilitates embryogenesis, growth, maturation, and survival of the fetus by synthesizing steroid and peptide hormones, which modulate and transport the maternal fuels to the fetus. Now, we all understand that insulin is an anabolic hormone, glucagon is a catabolic hormone. So, maternal plasma glucose is maintained by a coordinated action between insulin and glucagon. So, in a normal pregnancy, what are the metabolic maternal adaptations that will occur? In early pregnancy, the fetus is still developing, it is still growing. So initially, what we need is maternal metabolism has to facilitate developing of the anabolic stores in the early pregnancy. Beyond the second trimester, what happens is fetus has to prepare to come out. So the organ systems are formed, but now the physiological functions have to come in. So that is why the anabolic stores that are developed in early pregnancy, now the metabolism has to change to meet the metabolic demands of late pregnancy. So in the first half of pregnancy, what we see is basically a facilitated insulin action because we need a lot of anabolic action here. And in the second half of pregnancy, like I said, the placental hormones are peaking. So they are increasing the insulin resistance because of the diabetogenic stress of these hormones. So if you look at the changes in early pregnancy, estrogen progesterone levels are going up. These lead to beta cell hyperplasia and increased insulin secretion. So there's a state of hyperinsulinemia that is occurring in a normal pregnancy, early pregnancy. Now, what happens because of this increasing insulin that is being produced? There is increased insulin-mediated glucose disposal. So peripheral glucose utilization will increase, hepatic glucose production will go down, tissue glycogen stores are being built up. So because of this, what happens? Insulin sensitivity improves. So in early pregnancy, you see an improvement in the insulin sensitivity. Remember this point because we'll come back to this point when we are talking about insulin dose management in pre-existing diabetes. So in the first half of pregnancy, because of hyperinsulinemia, peripheral insulin sensitivity improves. So as a result, anabolic changes happen. Now, in the second and the third trimester, I told you the placental hormones are going up. We also know that in pregnancy, inflammatory markers, adipokines, cytokines also go up. There's a state of subclinical inflammation that's happening. All of these, including the placental hormones, are increasing the insulin resistance. Now, when the mother's beta cells are perfectly healthy, she has no diabetes, no pre-diabetes, no risk factors for GDM, what will happen is when there is increase in insulin resistance, the beta cells will produce more and more insulin to compensate for this insulin resistance to keep the glucose levels in the euglycemic or the normal range. So as a result, what happens is there is a compensatory 200 to 250% increase in insulin secretion in the late pregnancy, but the glucose levels stay in the normal zone because of this compensation, which is successfully able to control the glucose levels of the mother. Now, I told you initially that the maternal metabolism is changing in pregnancy because all the nutrients have to be supplied to the fetus. Now, the fetus needs a continuous supply of nutrients, but the mother is not going to eat 24 hours. She is going to eat intermittently. So, Norman Frankel very beautifully coined this term, saying that fetus is a continually feeding border in the body of the intermittently eating host or the mother. Therefore, maternal metabolism in pregnancy will change physiologically to provide an uninterrupted nutrient supply to the fetus for its growth and energy needs. So what happens? Now, when the mother is not eating in the unfed state, what happens? There is no exogenous fuel that is coming. There's no glucose. There's no mixed meal that she's eating. So to continuously meet the glucose demands of the fetus, there will be a continuous shunting of carbohydrates from the mother to the fetus. So since there is no external fuel that is coming, where will the glucose come from? From the hepatic neoglucogenesis. So hepatic neoglucogenesis will increase, and since we need to divert all the glucose to the fetus, what will happen is there will be increase in the peripheral insulin resistance, so that they don't take up the entire glucose and it shifts to the fetus. So skeletal muscle and the liver will become insulin resistant. This is the reason why even in a normal pregnancy, you will see that the maternal plasma glucose comes down a little lower than what it is when she is in the non-pregnant state. Now, as the pregnancy advances, the continuous shift of glucose to the fetus will continue. So fasting plasma glucose continues to be low in a normal pregnancy where she is not developing GDM. Now, neoglucogenesis is happening. So what is happening is circulating amino acids are being consumed, but protein is needed for the fetal growth. So the body has to utilize minimum protein so that most of the protein can be given to the fetus. So maternal metabolism, when she is in a fasting state, when she is in an unfed state, will stop utilizing the protein and it will shift to a catabolic state using fat as a source of fuel. Therefore, we say that in pregnancy, you see accelerated starvation and ketogenesis in the unfed state. What happens when she's eating a mixed meal? In the fed state, in response to a mixed meal, what will happen? Basal and glucose-stimulated insulin release will be increased. So the post-meal glucose load, along with the increased insulin levels, will blunt the glucagon secretion from the alpha cells, so that all the extra insulin that is being produced can compensate for the peripheral insulin resistance and blunt the gluconeogenic potential of glucagon, so that the amino acids that are ingested by the mother can be spared and not used by her for her metabolism, but shifted to the baby for the baby's anabolism. So in a fed state, what you see is a state of facilitated anabolism in the fed state. Now, once the carbs are disposed, mother should not go into a hypoglycemia. Therefore, the response of the alpha cells, which went down in response to that immediate post-meal load, that will stimulate enough gluconeogenesis to prevent reactive hypoglycemia in the mother. So, as a result, maternal fuel metabolism in a normal non-diabetic pregnancy is characterized by a state of accelerated starvation in the unfed state and facilitated anabolism in the fed state. So like you can see here, all the placental hormones that are increasing along with adipocytokines, and they have a diabetogenic effect on the maternal metabolism, increasing the insulin resistance as the pregnancy advances. As a result, there is a facilitated anabolism in the fed state, ensuring glucose and amino acid supply that happens continuously to the fetus. And when she is not eating, there is catabolism and an accelerated starvation that happens during fasting. This is the reason why, if a patient is fasting or is in starvation, the changes that will happen in a non-pregnant person over 72 hours, they happen much faster in pregnancy because of this hormonal, this maternal metabolic shift. So that is why within 18 hours, she can present with ketosis, starvation ketosis, if she is not eating in a normal pregnancy. And this is the reason why we tell pregnant women not to fast for long hours. So, in a normal pregnancy, what is the pattern of glycemia that you will see? Fasting will usually range about 70, 71. The 1 hour value stays less than 122 and the 2 hour value stays less than 110. So, in a normal pregnancy, the glucose levels stay on the lower side, and this is basically going to maintain a euglycemic state in the mother and the fetus, so that the growth can happen normally and there are no adverse effects. So in simple terms, there is a progressive change in maternal metabolism. As the glucose levels go up, increased compensatory insulin secretion is happening to keep the maternal plasma glucose levels in the normal range following any kind of mixed meal or glucose load. Now, when this compensation is going to fail, that is when gestational diabetes will occur. So in gestational diabetes, what is happening is, because of all these multifactorial mechanisms that you can see on the screen, there's increased insulin resistance, there's ectopic fat in the muscle, there's ectopic fat in the adipose tissues. When the mother is obese, they have pro-inflammatory milieu. The lipolysis is increased, there's expandability, goes down in the adipose tissue, and there's insulin resistance at the level of adipose tissue, there's insulin resistance at the level of liver. Even the role of gut microbiota in GDM, we all know about it now. So on a background of some amount of beta cell dysfunction, when this pregnancy happens, the compensatory insulin secretion, I told you there's an increase to almost 200 to 250%. If she is able to do that, her glucose levels will stay normal. If she has some amount of beta cell dysfunction, or if she has all those risk factors and peripheral insulin resistance, what will happen is this compensation will not be adequate. So this will not be adequate to keep the glucose levels to the normal side, and that is why GDM will occur. So majority of GDM, you will see some amount of beta cell dysfunction on a background of chronic insulin resistance. Now, when she gets pregnant, there's additive insulin resistance. So a greater degree of insulin resistance will happen in a woman with GDM compared to a woman who has no GDM in pregnancy, a healthy pregnant woman. So that is why we say that these beta cells will keep deteriorating due to excessive insulin production in response to excessive energy consumption and insulin resistance. As a result, dysglycemia happens when the compensatory hyperinsulinemia will fail and she will develop GDM. Now, why we are talking about GDM is because we know that this is just a transient state. 50% of women with GDM, however, will eventually in the next 5 to 10 years progress to develop impaired glucose tolerance or prediabetes and eventually transform to type 2 diabetes. And that is why we need to actually address this right in the beginning. Even in a pre-existing diabetes, what is happening? I told you, as the pregnancy is advancing, there's increasing insulin resistance, there's diabetogenic stress of placental hormones. This worsens the glycemic control of the mother. So she already has pre-existing type 1 or type 2 diabetes, but when this additive insulin resistance of pregnancy will happen, her glycemia is bound to worsen. That is why we tell them to keep increasing their insulin doses, and the pregnancy doses go up to almost they increase by almost 50% to almost double of the non-pregnant insulin doses that they were taking. And worse glycemia, we all know, leads to a lot of complications. And in pre-existing diabetes, we also see worsening of retinopathy, nephropathy, or neuropathy happening. Insulin resistance requirements are going up, maternal and fetal consequences may happen. So if the child is exposed to maternal hyperglycemia in utero, the child also develops a higher risk of developing obesity, metabolic syndrome, hypertension, or diabetes in the future. So maternal diabetes or gestational diabetes on a background of an obese mother or increased gestational weight gain creates a state of in utero overnutrition in the body. This leads to epigenetic changes in the baby's organs. So you can see muscles, pancreas, fat everywhere. So there is an altered physiology that can happen in the baby, in leading to increased insulin resistance, and the baby is born with some amount of inherent beta cell dysfunction. Therefore, when these children grow up, when they have been exposed intrauterine to hyperglycemia, these are the children who are born overweight, macrosomic, and they are the children who are at an increased risk of obesity, diabetes, and cardiovascular disease. And that is why we say the intergenerational effects and the long-term NCD burden cannot be reduced unless until we are able to keep the glucose levels in the normal range. If the glucose levels are not managed, what are the complications of hyperglycemia in pregnancy? Of course, in early pregnancy, in a pre-existing diabetes, if the glucose levels are not controlled, the biggest risk is congenital malformations. Neural tube defects are very, very common in women with uncontrolled diabetes in early pregnancy, anencephaly, microcephaly, congenital heart disease, sacral agenesis. One congenital anomaly, if somebody asks you, what happens in hyperglycemia in pregnancy if it is not controlled? Early pregnancy, 6 to 8 weeks, if the glucose levels are not controlled, sacral agenesis is very common. And then you have neural tube defects. And that is why we say folic acid supplementation should be done for all women who are planning pregnancy if they already have pre-existing diabetes or pre-diabetes. Miscarriages in early pregnancy are also very, very common. And then as the pregnancy advances, if the glucose levels are not controlled, there'll be a whole gamut of complications. Like I said, worsening of microvascular complications. She can immediately go into diabetic ketoacidosis, higher incidence of infections for the mother. Preeclampsia risk is increased if the mother has hyperglycemia. Risk of preterm labor is increased. Birth trauma, assisted delivery, cesarean sections. And like I said, for the fetus, polyhydramnios, fetal macrosomia, even difficult labor, prolonged labor, Erb's palsy, shoulder dystocia, these are very, very common presentations. And when the mother especially is on insulin during pregnancy, neonatal hypoglycemia is also something which is a very common complication. And that is why we say that during labor also glucose levels need to be maintained strictly. Neonatal hyperbilirubinemia, neonatal asphyxia are again very common complications that you see in uncontrolled diabetes, especially in pre-existing diabetes. Now, gestational diabetes, I told you, is hyperglycemia that is occurring usually in the later pregnancy. So, of course, congenital anomalies will not occur in a woman who gets GDM because that happens. Congenital anomalies you need early because 6 to 8 weeks is the time when the organogenesis is happening. In GDM, it is developing beyond 12 to 14 weeks when organogenesis has already been completed. So in GDM, you will not really see an increase in congenital anomalies, but spontaneous abortion, IUFD, infant respiratory distress syndrome, macrosomia, large for date birth injuries, shoulder dystocia, neonatal hypoglycemia, and large for date infants. And these are the children, when they are born to mothers with GDM, obese mothers, they have an increased risk of developing IGT. So these are the children who develop IGT as early as 7 to 11 years of age also. And like I said, for the mother also in GDM, if glucose levels are not controlled, polyhydramnios is a very common presentation that all of us see. Increased risk of prolonged labor, preterm delivery, C-sections, abortions, IUFD, uterine atony. Preeclampsia is again a very common complication that we see. So the recurrence rate of GDM is also very high. If she gets GDM in one pregnancy, post-delivery glucose levels go back to normal, but in the second pregnancy, she will again get GDM. 30 to 50% chances of developing GDM in a subsequent pregnancy. And that is why we tell them to plan the second pregnancy. So check their glucose levels, keep them baseline normal. And that is why preconception care and preconception glycemic control is very, very important. And like even in one pregnancy, if she develops GDM, the lifetime risk of developing type 2 diabetes goes up by almost 20 to 60%. So the effects of hyperglycemia or GDM do not happen only in that index pregnancy, but they lead to postpartum and beyond complications, including recurrence of GDM or progression to type 2 diabetes for the mother and for the child who is exposed to uncontrolled diabetes. Early pregnancy, I told you, congenital anomalies is very common, but long-term outcomes. These children are born, can be obese, they develop diabetes much earlier, they develop metabolic syndrome, hypertension, CVD much earlier. So screening is very, very important, especially pre-existing. I know you already diagnosed, so that's a different pathway. But a woman who gets pregnant should be screened for gestational diabetes. Now, this is where there is a difference between the global guidelines, the American or Caucasian guidelines, and the Indian or the Southeast Asian zone. Now, most of the Western guidelines talk about a targeted screening for GDM, because what they say is if the woman has not got any of the risk factors for GDM, then screening should be done only at 24 to 28 weeks of gestation. That is when the GDM develops. But now the American guidelines have also understood that it occurs early. And that is why now they say that in women who are planning pregnancy, all the women who have risk factors, I'll come to that in a little while, you should consider screening for GDM in the beginning, even before planning pregnancy. Furthermore, before 15 weeks of gestation, all women with risk factors should be screened for gestational diabetes at the first prenatal visit using standard diagnostic criteria if they have not been screened pre-conception. So, high risk women who have risk factors, they should be screened earlier. But if there are no risk factors, then they should be screened at 24 to 28 weeks, is what the American guidelines, the ADA, ESD say. But we know that Asian Indians are a very high risk ethnic group for development of diabetes. There is enough literature that tells us that Indian women have an 11-fold increased risk of developing GDM in pregnancy compared to the Caucasians or the whites. So clearly, all pregnant women in India have to be screened for GDM, and therefore in India, we have a universal approach for screening for GDM for all pregnant women. So the important question is, when should you screen? Well, like I said, a true gestational diabetes, the conventional GDM that we used to talk about, develops in mid to late pregnancy. However, I told you if screening is delayed till that time, there is a chance that if she has pre-existing diabetes, you will not be able to pick it up. Or early dysglycemia may be missed in this high-risk ethnic population like Indians. So it is indicated that we should do the first screening as early as possible, which means at the first antenatal visit in the first trimester as she comes to you for the first time when the UPT comes positive. So I hope I'm clear. In India, we need to screen all women. Ideally, pre-conception, they should be screened by normal 75-gram oral glucose tolerance test to see if they have pre-diabetes or diabetes. However, if that has still not been done, when they come to you at the first time, presenting with pregnancy in the first ANC visit, that is where you should immediately screen them for GDM. Now, the next question is, how do you screen? Well, there are a lot of recommendations. If you've read your gynae textbooks and all your textbooks, different guidelines in different countries will talk about different targets, different ways. So there's ADA guidelines, there's ACOG guidelines, WHO says something, NICE UK has a different guideline, IADPSG, which is commonly followed globally, has a different guideline, and DIPSI in India has a different guideline. So suffice it to say, no need to get confused. Two main criteria that you should know is IADPSG and the DIPSI. Now, IADPSG tells you that any woman who needs to be screened should be called fasting after 8 to 12 hours of fasting. You should check a fasting glucose, and then you should give her 75-gram oral glucose in 300 ml of water. She should drink it in 5 to 10 minutes. And then you note the time. Exactly 1 hour after the glucose and exactly 2 hours after the glucose, you should do a glucose sample. And if fasting is more than 92, or 1 hour value is more than 180, or 2 hour value is more than 153, you should diagnose her as GDM and follow the treatment pathway. Now in India, the problem is not all pregnant women will be able to come fasting to you. They just do a UPT, they've come to your OPD. Now, if you tell her to come fasting the next day, she may not turn up, especially in villages, class 2, class 3 cities. Husband is going on a job. Today I've taken leave. Tomorrow again I can't come. So that is why now the government of India, the WHO, FIGO have endorsed the DIPSI guidelines, which talk about a non-fasting screening. So here what we say is, when she comes to you in the OPD, irrespective of the last meal, all you need to do is give her 75 grams of oral glucose. make her sit for 2 hours, and then with a standardized glucometer, just do a plasma glucose, just do a capillary glucose. If that value is more than 140, diagnose her as GDM and advise her on MNT lifestyle and whatever treatment she needs. So these are the two main criteria you need to remember. There is more and more literature that comes about fasting dysglycemia. So the guidelines keep changing. So maybe very soon we will address that also. So when it comes to screening and diagnosis, I hope I'm clear. The one-step IAD-PASD strategy is commonly followed. There's another strategy, the two-step strategy, wherein first you do a 50-gram glucose load. That means you just make her drink 50-gram glucose, which is non-fasting. And then after 1 hour, you check if that is more than 130 to 140. Then you ask her to come fasting and do a 100-gram glucose, and you do 4 tests. Normally, this is outdated. We don't do it anymore. Now, different criteria I told you are country specific. So what does the WHO endorse? WHO says do a 75-gram oral glucose tolerance, do a fasting, and do a 2-hour value. If 2 hour is more than 140, then you diagnose her as dysglycemia. So India, I told you, DIPSI guidelines, 75-gram glucose, single test, universal screening, 2-hour post-glucose value more than 140. First testing is to be done, like I said, at the first trimester, when she comes to you in the ANC visit for the first time. If that is negative, repeat the screening, repeat this test. The second screening should be done at about 24 to 28 weeks. Still, if it is negative and she is obese, she is high risk, she has had history of PCOS, bad OBS history, first degree relative is positive, then these are high risk cases. Or if she's developing polyhydramnios, baby is going large for date, then you should do a repeat testing as late as 32 to 34 weeks may be indicated. So this is the Government of India endorsed document, and this is the latest. You can search in the IJDDC. You can just Google this document. This is the DIPSI document. I happen to be one of the lead authors here. So this has all the details of all the screening and everything in that. So you can go through this document at your free time. It is freely downloadable from IJDDC. Now, why do we need to control glucose? We've seen what the complications can be. So what are the target levels that you need to maintain in pregnancy? It has to be very tight, as good as normal pregnancy. What was the normal pregnancy I showed you? I showed you fasting stays around 71. 1 hour value is rarely beyond 120, and the 2 hour value is rarely beyond 110. Therefore, glucose levels have to be as tight so that the baby is not able to even perceive that the mother has diabetes. So DIPSI tells you that fasting should be maintained all through pregnancy between 80 to 90. Postprandial 2 hours should be maintained between 110 to 120, and mean plasma glucose or a random glucose should be between 95 to 105, so that the baby is not able to perceive maternal diabetes and there are no adverse maternal or fetal outcomes to prevent diabetes in the offspring as well. So glycemic targets, again, different guidelines will give you different targets, but you just need to remember two. One is the Western guidelines or the ADA, which tells you that fasting should be less than 95. 2-hour value should be less than 120. Most of the Western guidelines say if 2 hour is not possible, you can ask her to check the 1 hour post glucose also, and that should be less than 140. DIPSI tells you fasting should be less than 90 and 2 hour postprandial should be less than 120. What should be HbA1c target? HbA1c preconception should be between 6 to 6.5 or even less, but all through pregnancy, try to maintain it tighter. So in pregnancy, you should maintain it less than 6%. However, if it is a pre-existing type 1, who is on intensive insulin and she's getting very much of hypos all throughout, then you can relax the fasting target to about 100, max 110, and an HbA1c to less than 7%. Now, these days we use sensors, we use ambulatory glucose profiling, continuous glucose monitoring. So the time in range targets in pregnancy for type 1 diabetes, the target range is 63 to 140. I told you it has to be tight as a normal non-diabetic pregnancy. So the time in range between 63 to 140 for a pregnant woman with type 1 diabetes should be more than 70%. Above range should be less than 25%, and hypoglycemia should be less. So mild hypoglycemia, that means less than 63, should be less than 4%. Severe hypoglycemia should not happen in pregnancy, less than 1%. In gestational diabetes or type 2 diabetes, you need a little tighter glucose control, and a stronger, bigger target range. So time in range should be almost 85 to 90%. Hypoglycemia should be much less. Now, HbA1c in pregnancy is again a very important question. Should you do an HbA1c in pregnancy? Well, let me tell you, although A1c is useful, its utility is in first trimester when you want to rule out pre-existing diabetes. So if you've done a preconception HbA1c when woman already has diabetes, it should be less than 6.5, but we say aim for 6 or less so that pregnancy can proceed without complications. Max you allow is 6.5. Ideally, once she is pregnant, glucose level has to be tighter because it has been shown that if in pregnancy A1C can be maintained less than 6%, large for gestational age, risk is lowered, preeclampsia is lowered, preterm delivery is lowered. So if she can achieve a tight A1C of less than 6% in pregnancy without significant hypoglycemia, you should aim for that. However, if there is lot of hypoglycemia, target can be slightly relaxed. Now we know in pregnancy there is a rapid RBC turnover. So A1C cannot be done every 3 months because by that time the RBCs have already turned over. So if at all you want to use HbA1c to look at her glycemic control, the utility is only for 1 month. So you need to actually do a monthly A1C. So most of the guidelines tell you that there's no need to do an HbA1c. If at all, early pregnancy, 100% you should do it to rule out pre-existing diabetes. Beyond that, in second or third trimester, if at all you want to do an HbA1c, it will just tell you last 1 month. So nowadays we use fructosamine assay also, which tells you about the last 2 weeks of glycemic control. Now moving on to the management of hyperglycemia in pregnancy. The goal is not only to improve the perinatal outcomes, but also prevent long-term maternal and fetal effects. I told you the development of diabetes in the fetus, the child may develop metabolic syndrome, child may develop obesity if it is exposed to uncontrolled diabetes in utero. Therefore, if glycemic control can be maximized to the point that the fetus does not recognize that the mother has hyperglycemia, because the moment maternal glucose exceeds 140, it can be transferred from the placenta to the fetus. Now, fetus pancreas is formed by the time it is about 9 to 10 weeks. Insulin secretion in the fetus starts at 11 weeks. So, if the glucose levels are more than 140, then after 11 weeks, if the glucose is high, the fetal glucose will also increase and the fetal pancreas will also start producing insulin. So that is where we say the priming happens. So that has to be prevented if you want to prevent obesity and diabetes in the offspring. So you need to achieve a pregnancy outcome in a diabetic woman that is same as that of a non-diabetic pregnancy. So how do you manage hyperglycemia in pregnancy? 5 points. Psychological support is very important because she's so happy she's pregnant, and then you've done a glucose, you've done a GDM screening, and now you tell her that you have diabetes. So obviously you need to provide her a lot of psychological support. Tell her that you can control it with diet, with lifestyle, with whatever pharmacotherapy. We'll come to that. Exercise, lifestyle modification is very important. Medical nutrition therapy, and then we'll come to pharmacotherapy. Now, like I said, explain, reassure, and educate the patient that, okay, there are complications that can happen, but if you maintain the glucose levels in the normal range, I told you fasting less than 90 to 95, 2-hour post meal less than 120, breakfast, lunch, and dinner. If she is able to maintain this, you can reduce the risk of adverse maternal and neonatal complications. Physical activity, if she is not advised bed rest, or if she is not a very high risk pregnancy, if it is permitted, as much of physical activity as she can do, about 30 to 45 minutes of daily planned physical activity. She can start with walking, swimming is indicated. She can do upper body exercises even if she's on bed rest. So some form of physical activity she must definitely do. And MNT or medical nutrition therapy by a proper dietitian should be given to all of them. Small frequent meals. Almost 80% of GDMs can be controlled with MNT and lifestyle only. In case if glucose levels are still not controlled, she will need pharmacotherapy. Now, quickly moving to pharmacotherapy, oral drugs or insulin. Well, if you give oral drugs in pregnancy, what do you want? Either it should not cross placenta, or if it is crossing placenta, it should not cause fetal hypoglycemia, hyperinsulinemia, or teratogenicity. Therefore, most of the oral drugs are contraindicated in pregnancy. As you can see here, sulfonylureas cross placenta, they have been associated with neonatal hypoglycemia. Earlier, glyburide was used. NICE UK and FIGO still talks about glyburide, but lot of studies have showed that if she takes glyburide in pregnancy, neonatal hypoglycemia, macrosomia, increased neonatal abdominal circumference is seen. Long-term safety data is not available, so they are not recommended. So any woman with type 2 diabetes who is planning pregnancy, please stop sulfonylureas or all the oral drugs prior to conception, at least 2 to 3 months prior to conception. Same alpha glucosidase inhibitors, acarbose, only 2% is absorbed as an active drug. Few studies have now come in because we know these are postprandial regulators. So in gestational diabetes, where you see that because of insulin resistance, only the postprandial glucose is going up, a few studies have come in even from India, which have shown that postprandial control can be managed, but they have a lot of GI side effects. As of today, most of the global guidelines and even Indian guidelines do not advocate using any of these drugs. Maybe in the future, once we have more safety data, these could be promising candidates that can be used in pregnancy. Now, glitazones, again, pioglitazone crosses the placenta, rosiglitazone crosses the placenta. These are category C2 drugs. So animal data shows embryo-fetal toxicity. So they are clearly not recommended in pregnancy. Same for gliptins, not approved in pregnancy. Same for repaglinide, nataglinide, not approved in pregnancy. SGLT2 inhibitors and GLPs, these are newer drugs that we all use for diabetes management, but these drugs also have shown effect on fetal weight growth, and with GLP, skeletal ossification in animal studies is deranged. With SGLTs, we are seeing dilatation of renal pelvis and tubules, especially when it is continued in second and third trimester in some case studies. So unfavorable outcomes, none of them is indicated in pregnancy. In animal studies also, we have seen they are excreted in breast milk and they can affect growth, although we do not have human data, because you cannot do experiments in humans. So clearly, as of today, with the available evidence and case studies that we have with these drugs, they are not safe in pregnancy. So all the drugs that I told you, not indicated, not safe in pregnancy. What happens to metformin? Now, metformin readily crosses placenta, but it has been shown that it is non-teratogenic. Placenta, metformin is excreted even in breast milk, but the estimated infant dose is hardly less than 0.3% of the mother's dose. And no metformin was detected in the breastfed infant's plasma. And no adverse effects have been noted in children who are breastfed by mothers on metformin. So clearly, MIG study, metformin in GDM study, was a landmark study which showed that metformin was relatively safe in pregnancy. However, a lot of studies have shown that there may be a slightly increased risk of less maternal weight gain and prematurity with metformin. So if you have a pregnant lady who is on metformin, you need to follow her up very, very closely. In case you see IUGR, small for gestational age, infant developing, or you are seeing placental insufficiency, if she's developing preeclampsia, if the weight gain is gestational weight gain is not in the normal range, if you are seeing a poor growth, you should immediately withdraw metformin. Now, MITI trial was a landmark trial in women with type 2 diabetes who were given metformin in pregnancy. Clearly, insulin requirement was less, better glycemic control, less gestational weight gain, less cesarean births. So most of the things, it was found to be very normal, but some small for gestational age signal was seen. These children were further followed up because some studies have shown that children who are exposed to metformin in utero tend to develop obesity much faster. So this was MITI follow-up, 24-month follow-up of the MITI kids, clearly showing that anthropometric parameters were similar, BMI trajectories were similar. Now, this was another Nordic study which looked at congenital anomalies if metformin was given all through pregnancy. Clearly, no congenital anomalies, no additional risk was seen. This is the CLUE study group. Again, this is women with type 2 diabetes given metformin in early pregnancy, clearly showing that exposure to metformin did not really cause any harm if it was not causing benefit. But again, a small risk for gestational age was seen. Now, MOMPOD was a trial in gestational diabetes where metformin was given in addition to insulin to women with GDM. And again, here, what we saw was no harm with metformin. Rather, the trial was stopped prematurely. So all enrolled participants, they were given insulin, and based on their need, one arm was given placebo, one arm was given metformin. Clearly, metformin added to insulin did not reduce the frequency of any adverse outcomes. So there was no major benefit, but gestational weight gain was less. Insulin requirement was, of course, less. So clearly found to be safe. Using metformin plus insulin in pre-existing type 2 diabetes or GDM in early pregnancy did not reduce the composite neonatal adverse outcome. However, large for gestational age was reduced after adding metformin to insulin. Now, this is our Indian data from Dr. Yajnik's group, a 11-year follow-up of children exposed to metformin, clearly telling you that metformin use in pregnancy did not really show any major adverse effect. So clearly their BMI, waist significant, everything was normal. However, as pregnancy advances, lot of studies have shown that patient may need insulin. However, if it is a woman with GDM, but she is not getting controlled with MNT lifestyle or metformin, fasting is still more than 110, postprandial is still more than 140. If it is a high risk pregnancy, if the age of the mother is high on the higher side, more than 25, if you've detected GDM at less than 20 weeks, BMI, like I said, is high, then definitely, or if she has any complication, GI intolerance to metformin, renal or hepatic dysfunction, if she's developing polyhydramnios, if there's maternal or fetal distress, or any of the risks for hypertension, preeclampsia, or IUGR, you should immediately start insulin. You should not wait. So insulin is the gold standard preferred agent for managing any kind of diabetes in pregnancy because it does not cross placenta. So that is flat. It cannot cross placenta, so there's no way it can cause any kind of fetal harm. However, insulin therapy needs to be individualized. If it is gestational diabetes, maybe just a pre-meal bolus of a rapid-acting insulin is good enough to control the post-meal spike if the fasting glucose is normal. However, if the fasting is also high, you need to add a basal insulin. Similarly, for pre-gestational diabetes, all women with type 2 diabetes, I told you, preconception only, at least 3 months before they conceive, you should transfer them to insulin and aim for an HbA1c between 6 to 6.5%. And then once she gets pregnant, you can intensify the insulin. For type 1, obviously, insulin has to be continued. Of course, when it comes to insulins, all human insulins, regular insulin, Insulatard, NPH, they are found safe in pregnancy. When it comes to analog insulins, Aspart and Lispro, they are safe. Glulisine, there is no data, so we don't really use it much in pregnancy. Some studies are coming which show it is safe. Detemir insulin was approved for use in pregnancy, but now the Novo Nordisk is withdrawing Detemir. So now we have Glargine and Degludec, both of which can have been found safe in pregnancy and can be good basal insulins that you can prescribe to your patients if there is a need for basal insulin as well. So like I said, frequent dose titrations are very important. If it is pre-existing diabetes, I told you initially when I was talking about the physiological changes, I told you that glucose levels are less because insulin sensitivity improves in early pregnancy because of all the improvement in insulin sensitivity. So in early pregnancy, you may actually see a slight reduction in insulin dose. Compared to the pre-pregnancy dose. However, as she progresses from 12 to 16 weeks and beyond, the increasing diabetogenic stress of placental hormones will increase the insulin resistance, and therefore a 5 to 10% increment every week or bi-weekly you will see happening. So tell her not to get worried if the insulin requirement is increasing. Rather, if the insulin requirement is stable, you should worry, because as the fetal growth will happen, she will need more and more insulin. Once she's at 36 weeks, it will plateau, it will stabilize, and then by 38 weeks, it starts declining. Once she delivers, post-delivery, you will see a major reduction. If it is already a pre-existing diabetes, the diabetes is going to continue. But you need to immediately reduce the insulin dose to almost 20 to 40%, and then based on the self-monitoring, you can increase or reduce the insulin doses. Pumps can also be used. Of course, any woman prior to pregnancy, if she needs to maintain her blood pressure also very tightly. So there, if she is on ACE inhibitor, ARBs, all these drugs pre-conception should be stopped. Statins should also be stopped. And during pregnancy, the only antihypertensives found safe are methyldopa, nifedipine, labetalol, diltiazem, clonidine, and prazosin. Atenolol is not recommended. You should stop this. But other beta blockers may be used. So, plus to prevent preeclampsia, It is very, very important. You need to give low dose aspirin, about 75 to 150, starting at about 12 to 16 weeks. So this is the FIGO guideline I told you, which says that in GDM, you may use, if insulin should be advised, if she's not willing. FIGO talks about glyburide, but ADA clearly tells you can give metformin only if she's not accepting insulin or cannot take insulin for whatever reason. However, where should you not give metformin is very, very important. Any pregnancy where you see growth restriction, acidosis, placental insufficiency, metformin should not be used. Hypertension, preeclampsia, IUGR, metformin should be immediately stopped, should not be used. So clearly, this is the DIPSI document. You can see this on IJDDC. And because of all the favorable data that has come in India also, just last year, as early as July 24, the DCGI has also given approval of using metformin in pregnancies where it is needed. So based on the patient selection, it can be done. Just a quick word on delivery. A lot of us feel that if the woman has diabetes, you should do a preterm delivery. No. If everything is normal, metabolic control is good, fetal growth is normal, fetal weight is normal, BPD is normal, amniotic fluid is fine, you plan a full-term normal delivery. However, in case you see macrosomia, polyhydramnios, or any complication, that is when you can plan an earlier delivery. But advancing pregnancy beyond 38 weeks is not indicated, because after that, if the pregnancy is continued, risk of IUFD is again increased in hyperglycemic pregnancies. So management in labor, I will not cover. That's a completely different topic, but this is a guideline which gives you a detail of how labor should be managed in pregnant women with diabetes. You can download this and see. So to summarize, hyperglycemia in pregnancy or GDM is associated with an increased risk of maternal and fetal complications. Guidelines recommend early screening and diagnosis of GDM and optimized glycemic control to prevent maternal and fetal complications and to improve outcomes. Medical nutrition therapy and lifestyle is the mainstay for all kind of dysglycemia management in pregnancy. When it comes to pharmacotherapy, insulin is the preferred agent because it does not cross placenta, so it cannot cause fetal harm. Insulin therapy needs to be individualized. When it comes to oral agents, none of the oral agents as of today is recommended by any guideline, except for maybe metformin, which can be a good alternative if dysglycemia is of a milder degree. However, if she is not controlled on metformin, or I told you the contraindications, that is where you should immediately stop metformin and put her on insulin. And once she's delivered, if she's developed GDM, she should be again retested with a 75-gram glucose test 4 to 12 weeks after delivery, and then every year onwards. And you should always talk to these patients about the importance of planning the next pregnancy and preconception control. So with that, I think it's been very comprehensive, but I hope I've given you a decent overview of pregnancy and diabetes, different spectrums, and we can have some discussion and question answers. If anybody has any queries, you can just unmute yourself and ask me. Any clarification you need or any queries you have, you can unmute and ask me before we wind up. I know this was very extensive, but I tried to cover both pre-GDM and GDM for all of you. So there's a question on insulin requirement dose in each trimester. I showed you that table. So like I said, if it is a pre-existing diabetes, pre-GDM who is on insulin, in the first trimester in early pregnancy, I showed you the physiological changes will improve the insulin sensitivity. So the insulin requirement will be a little less, 10 to 20% less than the pre-pregnancy dose. Beyond that, second and third pregnancy, it will increase. If you ask me per kilogram dose, now this is again, if it is a pre-gestational diabetes, then normally we tell you that 0.2 to 0.4 milligrams you can start, and then based on the SMBG, you can increase. If it is an obese pregnancy with type 2 diabetes, her insulin requirement is going to be much more. So 0.5 units, you can start with 0.5 units per kilogram. So you can divide it between basal and bolus and then decide. So 50% as basal, 50% divided into 3 as bolus insulin. That's how we initiate a basal bolus regime for most of these ladies. And then second and third trimester, the requirement will go up to as high as 1 to 2 units per kilogram. So an obese type 2 diabetic woman, in my own clinic practice, we've gone up to almost 200 units. That's the amount of insulin resistance you see. So a woman who's already 110 kilograms, for her, there is going to be extreme insulin resistance. So you just keep increasing the doses. So, you need to ask her to do a lot of self-monitoring of glucose with the glucometer. And then if she's not on target, teach her how to increase the insulin doses. That's very important. Okay, so let me see what are the other questions. Insulin requirement in each trimester, I told you, you can start with 0.1 to 0.2 units per kilogram in the early this thing, if it is a newly diagnosed diabetic. And then in the second and third, it may go up to 0.5 to even 1 unit or 1.5 to 2 units per kilogram, depends on the amount of insulin resistance she has. How anemia in pregnancy influences HbA1c? Yes, this is a good question. I told you, HbA1c in pregnancy loses its relevance. As it is in a pregnancy, what is happening is RBC turnover is very rapid. What is HbA1c? HbA1c is glycosylated hemoglobin. Now, RBC lifespan is about 3 months, 120 days normally in a non-pregnant adult. So, in a non-pregnant adult, when you do an HbA1c, it will give you a clear picture of the last 3 months of glycemic control. However, even in a non-pregnant person, if he is anemic or if there is chronic anemia, HbA1c may be false low or false high. Even in iron deficiency, you will see sometimes a false high HbA1c. So and then in pregnancy, I told you the RBC turnover is also much faster, hardly 30 days. So if you do an HbA1c and the hemoglobin levels are normal, there are no hemoglobinopathies. Somebody who's got thalassemia minor, there also you will see the HB is low. If the HB is low, automatically the HbA1c will also be false low. So HbA1c is not a standard marker for glycemic control, especially in pregnancy. Nowadays, we talk of self-monitoring glucose, look at the fasting, look at the postprandial, and continuous glucose monitoring. We talk of time in range. So they are better parameters to tell you what is the glycemic control. What about human insulin and Mixtard? Well, Mixtard insulin does not really give good glycemic control. Earlier, the DIPSI guidelines also talked about Mixtard because in rural areas, sometimes all these different insulins may not be available. So where you just have to give insulin, but nothing is available, of course, you can use Mixtard. But honestly, in my opinion, if you have access to analogs, they work better. But if your patient cannot afford analogs, that means Lispro, Aspart, Degludec, even the human insulins, conventional human insulins like an Actrapid or a Hum insulin R, they can be used as pre-meal insulins, and a glargine insulin can be used as a basal insulin because you need very tight control. I told you 2-hour post-meal has to be less than 120. Normally with Mixtard, which is a mixture of 30% slow rapid acting, and 70% protaminated insulin, it will not be able to control that immediate 2-hour postprandial. Even if you are able to increase the Mixtard dose for the morning, you cannot give it 3 times in a day because then there will be hypoglycemia, and the post lunch will always be on the higher side. For all pregnant women who are on insulin, it is important to do at least 4 sugar tests every day if they do not do 6. Fasting 2 hours post breakfast, post lunch, and 2 hours post dinner. Fasting should be maintained strictly between 70 to 90, should not exceed 95. And 2-hour post meal should not exceed 120. So whatever X units of pre-meal insulin she is taking before the meal, check the post meal. If it is more than 120, ask her to increase the dose of pre-meal insulin. When she is taking Lantus, glargine insulin or Degludec insulin, check the fasting also. If the fasting is more than 95, you increase the dose of basal insulin. So if the post meal is not on target, you increase the pre-meal bolus insulin. If the fasting is not on target, you increase the basal insulin. Folic acid dose profile axis, yes, 5 milligrams folic acid is indicated for all women with pre-gestational diabetes, type 1 diabetes, pre-diabetes when they are planning a pregnancy, because folic acid has a very clear role in preventing neural tube defects. So all women with diabetes who are in the reproductive age group and are planning a pregnancy, a 5 milligram folic acid dose is strictly indicated at least 3 months prior to getting pregnant. So pre-conception, you should start and you should continue. Can we use both metformin and insulin in the same patient? Yes. If she does not have contraindications to metformin, I told you IUGR, preeclampsia, hypertension, uteroplacental insufficiency, a woman who is obese, even if she's got GDM, there, if you are using insulin, you can add on metformin, because of course it has a role in reducing insulin resistance as well. If she can tolerate metformin, you can use 500 TDS, or you can even do 1 gram twice a day. You can titrate the metformin if she is tolerating, but monitor the gestational weight gain, monitor the fetal growth, monitor the amniotic fluid. If any of these is going on the lower side, immediately you need to stop. Plus, if she is getting GI intolerance or if she has hepatic or renal dysfunction, you should not use metformin. Otherwise, metformin has a good use along with insulin, because it keeps the insulin doses also a little in check. Artificial sweeteners in pregnancy, well, I for one do not clearly tell my patients not to use. Some of the artificial sweeteners have been found to be safe, but normally most of the people that I have talked to, we prefer not using artificial sweeteners at all, because it's just a matter of 9 months. Because a lot of artificial sweeteners eventually in the long term have shown some kind of side effects, memory loss, hepatotoxicity as well. So pregnancy is not a time where you want to take a risk. So my personal opinion is artificial sweeteners should not really be recommended in pregnancy. Insulin advice during intraoperative. Well, it's a very long chapter on how you start a DNS infusion, you monitor the glucose levels and you increase. That's why I showed you that RSSDI in hospital hyperglycemia guidelines. Please download that document. That has a whole section where we have very clearly mentioned how to start an IV insulin infusion and how to titrate the doses and how to monitor glucose levels in labor and postpartum. So just refer to that document. It will give you all the details. What type of exercise for GDM? See, if she is not on bed rest, if it's a normal pregnancy, proceeding normally, everything else is normal, she can do 1 hour of walk every day. Personally, for all my patients with diabetes or GDM, I tell them to walk after every meal. Because 1 hour after meal, if they do a 10 to 15 minutes walk, I have seen the postprandial spikes coming down a little. So if she can take a walk of about 10 to 15 minutes after every meal, that is very good. It reduces the post-meal spike. Otherwise, a 45 minutes to 1 hour walk is good enough, or in her comfort zone. If she cannot walk 45 minutes, even 20 minutes is good enough. Suppose she is on bed rest and cannot do walking, or any of the other exercise, anything that is not making her jump or not which is not risking the pregnancy, that exercise she can do. These days a lot of them do Lamaze exercises, a lot of them do swimming. Swimming is very safe in pregnancy. However, if she's on bed rest, upper body exercises, so just moving the arms up and down, that kind of exercises. Also, we tell them move your legs, move your arms, because any form of exercise is good because it breaks down the insulin resistance. So the glycemic spikes can be reduced if she is exercising well. And meals also, we tell them not to have a full stomach meal. They should ideally have small frequent meals. So every 3 hours she can have a small snack or a meal, rather than eating continuously on a full stomach and not eating for 6 hours. Because see, there's so much of insulin resistance that's happening in pregnancy. So if she's going to put a very long gap also between 2 meals, then also the glucose levels will go down. There'll be a hypoglycemia. So in pregnancy it is a very tightrope walk. She should not go above 120. She should not fall less than 170. Less than 70. So that is why between 70 to 120 maintaining is very difficult. Small frequent meals, small steps after every exercise, less of carbs, more of proteins and fibers. Don't put her on zero carb. Keto diets, all these fancy diets should not be done in pregnancy. Pregnancy is not the time for weight loss. So a normal standardized 175 grams of carb is indicated in pregnancy per day. So she can take a normal not very high carb. So maybe, lunch can be one chapati, breakfast can be maybe, eggs or upma or chila or whatever you prescribe. So between breakfast and lunch, ask her to have a single fruit, a small fruit, cricket ball size is indicated. No fruits are contraindicated, except obviously banana, which is a very starchy this thing, and maybe mango also. If she wants one slice of mango, we tell them to take. So I think small frequent meals, breakfast, mid-morning snack, lunch, mid-evening snack, and dinner, and maybe a bedtime fruit or nuts is very important. Fetal abdominal circumference role. Obviously, you need to monitor the abdominal circumference, because obviously this is going to tell you the if the mother's abdominal circumference is going up, it will tell you polyhydramnios. For the fetus, also hyperinsulinemic baby. I told you, if the baby is getting exposed to increased glucose, if the mother glucose is not controlled, I told you by 11 weeks, the fetal beta cells are capable of producing insulin. So what will happen is, if the mother's glucose is more than 140, through the placenta, it will enter the fetus. The fetus pancreas is already capable of producing insulin. It will start producing more insulin. So there'll be fetal hyperinsulinemia. Now now baby does not need this, but it is producing insulin. Now insulin, I told you, is anabolic. So as a result, these children start becoming macrosomic. So that is why importance of all this monitoring is very, very important. So I think I've taken all the queries. I hope the lecture is useful, and maybe we can log out. We can finish this session. So we'll log out. Thank you so much. If you have any queries, you can definitely reach out to me. I'm based in Delhi, so you can send me a mail at my mail ID. Thank you so much. So we can all log out. Thank you so much. Bye.
Thank you.
Thank you.